Alex Card, and I'm a resident at Kettering Health. I'm here to present a case on a delayed presentation of an anterior wall STEMI with ventricular fibrillation arrest after jailing the acute marginal branch artery. As for a little bit of background about this case before we begin, typically ST elevation myocardial infarctions require emergent interventions as delay in treatment results in increased mortality. Usually, anterior STEMIs are often due to thrombotic occlusion of the left anterior descending artery. However, there have been a few reports of isolated anterior ST elevation changes on EKG that were associated with right coronary artery ischemia and infarction. During percutaneous intervention, oftentimes side branches are occluded or jailed by stents. In this case, the acute marginal artery was jailed during PCI to the right coronary artery. These usually do not have many complications. The objective of this case is to elucidate the significance of protecting side branches during PCI. Specifically, we hope to highlight the consequence of occluding the acute marginal branch when stenting the right coronary artery. As for the case, a 53-year-old man presented with unstable angina, had a positive stress test, and was referred for urgent cardiac catheterization. A pre-procedural EKG was significant for some T-wave abnormalities in the inferior leads. Coronary angiography revealed severe disease involving the right coronary artery, as seen in Figure 1A on the left of your screen. There was also non-flow limiting lesions in the LAD that were not treated. A successful PCI was performed, and 2 overlapping drug-eluting stents were placed with 0% residual stenosis. However, as you can see in Figure 1B, the acute marginal artery was jailed and lost. Post-procedurally, about 30 minutes, the patient developed sudden onset chest pain, about 8 out of 10, and an EKG reveals what you see in Figure 2, isolated ST elevations in leads V1, V2, and V3. As you can see, there are no reciprocal changes on this EKG. He later developed ventricular fibrillation arrest, and after ACLS was performed, he was taken back to the cath lab. While in the cath lab, IVUS revealed a small non-flow limiting dissection in the distal RCA that was stented, but no further occlusion in the previously placed stents. The next day, subsequent EKG revealed resolution of the ST changes, and echocardiography revealed a normal EF of 55% with no regional wall motion abnormalities. The patient was later discharged home on optical medical therapy. The significance of this case in further discussion is to again elucidate how jailing side branches can present as ST elevation myocardial infarctions. There have been a small number of cases reported of anterior and left-sided EKG changes with RV infarcts, as in this one. However, this is less than 10% of patients. There's currently no criteria to guide the decision whether protecting or jailing side branches, especially of the RCA. On visual assessment, side branches greater than 1.5 millimeters in diameter should be considered for bifurcation. The resolve score was developed in order to accurately predict side branch occlusion when performing such interventions. Side branch occlusion has been associated with statistically significant higher in-hospital complications, including myocardial infarction. This case, again, shows the importance of protecting side branches when performing PCI to major epicardial arteries. In conclusion, occlusion of the marginal branch off the RCA and being jailed by PCI can mimic an anterior ST elevation myocardial infarction without any reciprocal changes. Keeping the branch patent during initial stenting would serve to prevent complications and unnecessary repeated cardiac catheterizations. If the acute marginal artery dominates a large portion of the anterior right ventricle, it would be worth considering keeping the branch patent. Furthermore, ventricular fibrillation arrest secondary to the AMA that was jailed during the PCI likely could have been prevented if this artery was kept patent. Thank you.